Good afternoon, everyone. I'd like to start by thanking Jill for inviting me to speak today. My name is Dr. Aoife Mahon. I'm a researcher at the University of Bedfordshire in the Institute for Health Research. Some of you may know me already as I'm conducting an evaluation of local MDTs, but my colleague Dr. Yanis Pappas is also on this webinar with me today. So over the next 20 minutes, I'm going to give a very brief overview of what the literature tells us about effective multidisciplinary teams. So let's start with what are MDTs? Well, I'm sure you're all familiar with the phrase integrated care, but I'm just going to provide a brief definition for that so we have a shared meaning throughout the presentation. Very briefly, integrated care is an holistic approach to patient care that's person-centered, coordinated, and tailored to the individual. Because of the nature of integrated care, it brings together professionals from many different services and types of disciplines, and they all have the overarching aim of developing the most appropriate care plans for and with patients. There's many different types of integrated care within the UK, for example, multidisciplinary care, interdisciplinary care ward rounds, and multidisciplinary team meetings, which we're going to discuss throughout this presentation. So MDTs specifically are a mechanism that allow for the sharing of information between various professionals that are involved in patient care. And they have the aim to provide the best possible outcomes for patients. So why are MDTs so widely used? Well, there's many perceived benefits of MDTs. On this slide, I've presented some of the findings from the National Cancer Action Team in a paper they published in 2010. In that paper, they do present more specific cancer care benefits, but I'm just going to discuss some generalized benefits of MDTs. So, overall, MDTs do assess patients on an individual basis, and through this, they offer more tailored levels of support and information, and this lets patients best cope with their condition. They allow for a continuity of care, especially because quite often care is provided by different services or different individuals. They also encourage good communication between primary, secondary, and tertiary care, and this allows for the promotion of good working relationships between those staff. This has a knock on effect where there's an enhanced job satisfaction for MDT members and improved quality of life. There's also improved quality of outcomes for patients because staff have a better understanding and awareness of patients' characteristics across services, and they use reflective practices. There's opportunities for education and professional development of all MDT members from junior to senior staff. And there's an optimization of resources. So, an effective MDT should result in efficient use of time and better use of services within the NHS in general. So, I just want to focus on that last point, the optimization of resources on this slide. In order for an MDT to be effective, there must be a buy in from those members that are involved in the MDT. And the buy in really happens when you see a benefit. So, although I discussed some of the patient benefits like better outcomes and improved tailored support, some of your professional day to day benefits like better communication and a better working environment between different sectors, there's also organizational benefits. So, in a paper published by NICE at the start of this year, 2018, they conducted a systematic review of MDTs within acute medical emergencies. So, this is an area that your MDTs might also be interested in because I'm aware that quite often one of your aims might be to reduce unexpected medical emergencies. So, in this paper, the authors conducted a cost analysis of the MDT. So, they wanted to see if the MDT was cost efficient. So, they tallied up the hourly salary of the MDT members, and from that, they subtracted the average excess bed day cost. So, here's a direct quote from that paper. And it says that MDT care showed a reduction in length of stay of 1.7 days per person. And based on the average excess bed day cost, which is £296, this resulted in a net saving of £228 per patient. So the MDT was cost effective. The authors go on to note that they're aware of an investment of time from the MDT members, but that this investment should at least be partially offset by the savings in terms of the reduction in length of stays and possible reduction in readmissions. And the authors conclude by supporting the use of MDTs within AME. But it's important to note that this is all based on effective MDTs. So, what makes an effective MDT? Interestingly, while MDTs are widely used and supported, there's no national guidelines or standard for MDTs. In general, the literature indicates that good planning and good communication are the best enablers or the most common enablers. But what are the specific characteristics of an effective MDT? Well, the National Cancer Action Team identified five main characteristics, and these are the team, the infrastructure for meetings, meeting organizational and logistics, a patient centered clinical decision making approach, and team governance. So I'm just going to go through each of those individually across the next 5 slides, beginning with the team. So thinking about the team, we'll begin with the membership. So all of those involved in the MDT must have relevant expertise for the patients that are being referred to that specific MDT. The coordinator, so the individual who's involved with setting the agenda, taking notes, etc., should be seen as a core member and present at all meetings. And all absences should be noted, but it's important that the members that are still at the meeting are cover any expertise that's missing by these absences. Then for attendance, all members should be given the time to travel, prepare and participate in the MDT. And core members should be expected at all MDTs because their level of expertise is necessary for the patients that are being discussed. Non-medical referrers or external referrers should be present when their cases are being discussed, and a register should be taken at all meetings. The chair has an important role within the meetings, but even in regard to attendance, the chair should be able to raise any attendance concerns and assess the level of expertise that's present when these absences occur. The chair is involved in the leadership of the team, so they're responsible for setting objectives and expectations for the team and for each meeting, and also escalating any issues that arise. They should ensure that all discussions are relevant, evidence based, and patient centered. And they do this through good communication and supporting good communication between the team. The team itself, everyone should have a defined role, and the role should be understood by all members of the team. And you should be active in your sharing of information, not just for your patient, but also providing information for other patients. There should be mutual respect where all individuals feel like they can ask questions or raise any issues that they may have. And the team should encourage professional development and personal development through training, networking, and supporting learning. The second characteristic is infrastructure for meetings. So this is the real physicality of the meeting. So the meeting should take place in a dedicated room in a quiet location. And as basic as it sounds, all members should have a seat and can be seen and heard by each other. If this doesn't happen, it is detrimental to the meeting. Technology and equipment. If technology and equipment are being used, it's important that the core members, but specifically the coordinator and the chair, know how to use that technology and how to address any issues if they arise. There should also be some form of assistance on site just in case these issues do arise and they can't be fixed easily. There's some support for the use of a projection equipment. So, for example, if you have a very complex case or delivering any training or learning, you might want to use a projector and some type of real time equipment that the coordinator can use to document recommendations. You might also want to consider conferencing facilities, so video conferencing facilities, for example. So, for example, if a specific type of expertise is needed for a complex patient, that individual might need to conference in, or if some individual can't make it for any particular reason. The third characteristic, meeting organization and logistics, revolves around what happens before the meetings, during the meetings, and after the meetings. So we'll begin with the scheduling of the meetings. Meetings should be held as regular as needed by the patients, and this can be continually reevaluated. And this should be held during core hours, so this is something that's set out in your own specific job plans, and they shouldn't clash with other clinics. Prior to the meeting, the agenda should be set, and this allows for the team to make sure that they have sufficient time for all cases, especially complex cases which often need more time. You might want to set a minimum standard of information that's collected for all patients, and this is agreed with all members. And this includes clinical information, but also the patient's history, patient views, and patient preferences. When you're preparing for the meeting, you might also want to think about specific questions that you want the MDT to answer or that you want to bring, and this will help to set the agenda and set times. Then during the meeting, it should be mutually agreed who is discussed and why, and make sure that all relevant notes are available at the meeting so the most up-to-date information is available. The coordinators should capture in real time the recommendations, making sure they don't miss any information. And again, it sounds basic, but phones are off or silent. And again, the chair is constantly thinking about how to be more effective in the chairing of the discussion. Then, after the meeting has taken place, there should be processes in place that communicate the MDT recommendations, and this is communicated back to the patient, to, to the patient's GP, for example, and any local teams that are involved in the patient's recommendation care plans. You want to set agreed timeframes and make sure that patient needs are being met. If actions and recommendations aren't implemented, this should be fed back to the MDT as well. You might want to think about any way of referring patients between MDTs and tracking patients through the system. The fourth characteristic is patient-centered clinical decision-making approach. So this begins with who's discussed at the meetings. There should be a local process that identifies appropriate patients. And you can only identify appropriate patients by having clear referral criteria. So understanding who the MDT should assess, how they're going to help, and what questions are asked of the MDT. And this allows for a mutual agreement of who and when patients are discussed. Thinking about patient, the MDT should be patient-centered. So patients should be made aware of the MDT, of its aims, its processes, and how it might help them. And their views and preferences should be discussed at the meeting, especially when setting recommendations. Any individual who's met the patient ideally should be discussing the patient or at least present. And the patient should have a named key worker and a named individual who ensures that their objectives and that their needs are being met. For clinical decision-making processes to be effective, you must make sure that information is available during the meeting and that this information is up to date. And this lets the MDT discuss all options, even non-local options, so best processes are being followed. You should think about the patient in a holistic way. So think about their socio-demographic profile, their views, their preferences, and all recommendations that are made must be clear, patient-centered, in line with standard procedures, evidence-based, and communicated back to the patient. The last characteristic of an effective MDT is team governance. So this is looking internally. So because all of the members come from different organizations, you want to have organizational support. So the employers should recognize that the MDT is a model that delivers safe and high quality care. And this support can come through adequate funding or any type of support that may be needed by the member. And they can review annually their support and the MDT's membership and address any issues or concerns that are raised. So thinking about auditing or evaluating the MDT, information should be provided, collected, and fed back in a timely manner. And internal and external audits allow for assessments of whether best practices are being followed, and you might want to think about using patient feedback and patient surveys. Then clinical governance. So you must make sure that the purpose and outputs of the MDT are clearly explained and that the MDT follows agreed protocols. Again, you might want to use user partnership groups. And a mechanism should be in place to inform the MDT of when recommendations aren't being followed and why, and if any complications occur. A nice recommendation from this paper was that what MDTs could do is they could meet with other local MDTs within the trust and share best practices and discuss local problems. So across the slides, I've presented some of the key findings about effective MDTs, including the benefits of MDTs and the characteristics. And I'm going to conclude with a quote from the NICE guidelines that I mentioned at the start. And the quote goes like this: it is often assumed that this form of working is easy and simple to implement. To achieve effective MDT working, some training is required to ensure members understand and value the roles of each other and develop an ethos of working as a member of a team, particularly focusing on providing the best possible outcomes for patients. And I think this pretty much sums up an effective MDT and the ethos and the aim behind it. So I'm just going to finish with that. If you have any questions, please send them to Jill or directly to myself. I've provided my email address on the first slide. Thank you very much for your time, and thank you very much for listening.
So just thinking about your role, particularly as chairs in the MDT, I just wanted to recap the cluster MDT aims and objectives, which should be being reproduced on every agenda, which was actually one of Tara's requests early on. If they're not on your agenda, then speak to your coordinator and do ask them to make sure they include them, because it does just help perhaps to focus the meeting on, what are we here for, and what are we trying to achieve. And really the intention is, as far as possible, that the discussions are focused discussions that are clear about where are we going with this patient, what outcomes are we trying to achieve, what particular actions need to be implemented for them, and if those things are done, then we should be hopefully achieving these aims. One of the things that I would be interested to know about is, and one of the questions that is being so for those of you who are in Bedford, you may be aware that we currently have the University of Bedfordshire doing an evaluation of the groups that have been happening in Chiltern Vale for a little while. So we will have a sort of more properly researched evaluation carried out. But one of the questions they're asking is about aims and objectives, and feedback I would be interested to know is, do we have the right aims? Are we focusing on the right things? Or actually, is part of our planning for going forward changing some of these, tweaking some of these, taking some out, putting some other ones in? I don't know, but that's just sort of food for thought for you, really. So if I just have a look at the actual patient log, hopefully this is fairly familiar to all of you. So you should have for each of your groups, you should have for all of your patients a log, which the first few columns look something like this. And I just wanted to sort of go over what those bits are, why they're there, and what they're intended to achieve. So the first one is usually the third column along, and these are all information which should be completed by the MDT coordinator, hopefully from the referral form. That does assume, of course, that the referrer has filled everything in, and that the referrer themselves are clear on some of the things they want, because something I am aware of in talking to different referrers is that sometimes they they're not. They know they've got an issue. They know they want, the group to look at a patient or to discuss a patient. But sometimes they're not completely clear what services may be available to that patient, and sometimes they find it hard to articulate what outcome do I want from this. I just know that we need to improve things, or that I need some help. But it's hard to say, really clearly exactly what outcome I want, if that makes sense, other than things being better. And I think sometimes it's useful for the group, if the referrer hasn't been able to articulate that initially and it's not been captured on the patient log, it would be helpful for you as chair to be helping perhaps to ask those questions at the meeting, and actually be asking the group, where are we going with this patient, what do we want for this patient, and trying to make sure that that is captured, because if you have that captured, it will help you to focus your discussions on, where you're going and what you're doing. Obviously, the coordinator should be piping up and asking if there's gaps, but equally, for you as chair, you can help direct that discussion. Another thing that is often not completed is the patient's desired outcome, and I think sometimes it depends on. Some referrers are very good at capturing the patient's desired outcome. Others really struggle, so some find it really hard to know. What does the patient want? I know, Tara, we've had some discussions about, is this the right question anyway? So I think that's something we need to look at. It's trying to get some idea of what does the patient want in the situation. Is what they want the same as what the clinical staff want or the social care staff want, or actually do they want something completely different? It may be that what they want isn't achievable, but that they want something which actually either isn't safe, or that can't be delivered, or that just isn't we can't, it's beyond our remit, but at least understanding that that's what they have in mind, or that's what's important to them, can be, again, helpful in just in gauging where are we going with this person. Is where we think we need to go actually where they want to go? Is it part of what they want? And again, it's sometimes something that you may need to make sure is discussed in the meeting rather than it always being clear from the initial referral. Another area is the key worker. Now, we put in a key worker into the process at the very beginning because it felt important that there would be one person, apart from the group chair who's keeping an overview of all the people on the caseload. It felt important that a key worker from within the group was assigned, and it's usually the person who is most involved with that patient. So it doesn't necessarily mean that they're doing everything, but it just means that perhaps they are the one, from the point of view of the group, is keeping an eye on, we said we'd do this. Has this happened? Hasn't it happened? What are the issues? Why, why can't we do these things? And by having a key worker, it helps to, again, just bring that, that extra person who's focusing on that person. It's interesting when I look at the logs, because I see that in nearly all cases that a key worker isn't explicitly noted, and it may be because this isn't being discussed in the groups. It may be because it's not considered useful. Perhaps it's because people aren't completely clear what the role is. We set it out, so in the operating model, which I think I also circulated to you before the meeting, we said it's that person is responsible for monitoring the action plan agreed for that patient by the group. So it's not meant to be a hugely onerous role, but again, it would be, I'd really appreciate it perhaps if you could focus on, when you're preparing for your meetings, if you see there are, key workers not assigned, as you get to that patient for discussion, maybe be, asking the question, who is the key worker of this person? Who are we agreeing? And, helping to make sure the coordinator has that information and can note it down. So theoretically, if everything is completed as it should be, you should end up hopefully with something that looks a bit like this. And if you have all that information in place, theoretically, that should help focus your discussion. Now, I appreciate that people don't always fit neatly into boxes, and especially these very complex patients, but again, it's about trying to just make sure that as much as possible what we're capturing really supports the discussions. On to the next bit. So you should have action plan agreed for each patient. So following sort of an initial, what are the presenting needs? Where are we going with this person? Generally speaking, there needs to be some actions that happen. Sometimes I know, again, from what I see in meetings, sometimes it's not quite as clear cut as, well, we'll do this and we'll do that and we'll do the other. But nevertheless, something needs to happen, even if it's going away and asking about something. Sometimes I don't think I see it so much in the Bedford groups, because most of you, Chris and Eileen, support your groups. But what I see sometimes is the action is bring back in 2 weeks, and I think, well, that's not really an action, is it? I mean, I know sometimes it needs to, we just need to sort of monitor a bit and wait and see what happens. But the action should really be about perhaps a referral somewhere, or a visit that's agreed, or something concrete that will be happening to or with that patient in order to try and move things forward. And that can obviously be updated as further actions are agreed. So, what you agree at the beginning may not be then what becomes, maybe as things progress that you find that needs to change, or something else needs to happen, or and so on. But the column after that then is for the, the update. So, these are things we agreed. Have we actually done them or not? So that's what should be happening in the next column. So really what you get hopefully is a story. And it might seem a bit pedantic to keep the actions distinct from the updates, but just trying to do that, it does help in terms of when we're trying to come and look at, what's happening with these patients, and when we're trying to sort of get some overview of, what's happened with these patients. It really helps us as well as helping you. So it's for you to be more focused, but it's equally as we're trying to sort of monitor and assess and measure, is this right or not? Having it clear makes a real difference. And then at the very end, you've got these 4 columns, which are just to be completed at the point of discharge. So when you as a group decide either we've got as far as we can with this patient, or sometimes somebody passes away, sometimes somebody moves away, but hopefully in most cases there's been either some level of resolution, or sometimes actually perhaps it can't be resolved, but we've sort of done as much as we can. the number of months on the caseload, obviously the coordinator will just add that up, that's fine. But the other ones, the outcome on discharge, whether or not the patient goals have been achieved and whether or not any admissions have been avoided, those are really the opinion of the group. Particularly the admissions avoidance, it's not an absolutely clear scientific, yes, 3 were or 1 was, or, but it's an overview. Do we think as a result of the discussions that have happened here that, the actions we've taken, we have actually stopped this person going into hospital? In some cases that's not relevant because that wasn't the initial presenting problem anyway, but it's partly just to help keep a little bit of focus on, this is one of the goals of these meetings, and, just to help focus on, one of the reasons why we're here really, and it sort of gives some idea of things that we can then triangulate with our more sort of formal secondary care data and that we can look at. So again, it's not so much for the coordinator to go and finish that herself after the meeting. It's more for the group discussion really, and for those particular bits, and also it helps in terms of communicating back to other services. This is where we got to with this person. I just wanted to update you a little bit as well about some of the current developments. So I think the first few months after you got started in July, it was very much about just getting things happening, getting everybody settled in, getting something, getting the meetings going. But as we've progressed, we are now looking more formally at how we link in better with other agencies. So, for example, the respiratory multidisciplinary teams in the hospital, the integrated community diabetes services, heart failure nurses in the community. TVNs, I think most of them have been on the mailing list for the groups in Bedford, but, again, how we bring those in as needed. Some groups have had Path to Recovery along. I know, Ravi, you mentioned somebody who came to from the ambulance service, so again, we're trying to make sure that we bring them in as needed. And the other thing we're trying to do is make sure that bit by bit we are circulating information about local voluntary agencies where sometimes they may be more appropriate to help with some of the patients. So it's initially tended to go to the coordinators and then for them to sort of disseminate to groups as relevant. And that's something we want to keep on developing. So there is a sort of a bit of a sense of, not just from the core people within the group, what are the other things that we may wish to pull in occasionally, they may wish to come and refer into us and visit us sometimes, but also how can we link in better and a bit more seamlessly with some of their services and some of the work they're doing. Dial-in facilities is something which several groups have asked about, and I think one of the groups in Bedford is up and running with that because they already had that in the surgery. I think by preference we do want as much as possible groups to be people physically in a room so they can talk to each other, but we do absolutely understand that sometimes it's just not possible, and sometimes it's more efficient use of time for there to be a dial-in rather than physically travelling to a building. The issues have just been because all the practices have different telecoms providers, so it's not been an easy thing to implement everywhere. But we are looking with the CCG's IT team at what technological solutions we can put in place, maybe using Skype for Business or other facilities. I've just finished a report on Q2, which finished in September, so I know we're already nearly at the end of Q3, but it does give some facts and figures about numbers of referrals and some of the outcomes, so I'll be circulating that to everybody imminently, which hopefully you'll find that interesting just to see a bit of what's happening across the patch. We're linking in very closely with the High Intensity User Project, which again I think you're aware of. It'll be interesting to see how many of the patients are actually then suitable for bringing to MDTs, and again that's something I think will be interesting to see, because it may be that actually some of those patients need a slightly different approach. And in Central Bedfordshire they are pushing very much what they're calling a multidisciplinary approach, where they're trying to bring together their social workers, their mental health workers and the community nursing teams, working much more closely together. So although that's not officially part of Bedford Borough's strategy, it's certainly an approach and a way of thinking and closer integrations that they're very in favour of. So while it's sort of a slightly more formalised work stream in Central Bedfordshire, the intention is similar in Bedford, and that's something we're working quite closely on with our MDTs. Sorry, let me just go to the next place. The other thing which we are looking to do is have a very clear shared care plan for all the patients who are on the caseload. This is something which I will be talking to the coordinators about in more detail over the next few weeks and months, and it's intended to sort of help share information better around the different teams, but equally will hopefully help focus discussions for you a little bit. So I will send a draft template round to all of you with the slides after the meeting, and I would welcome any comments. So if you've got thoughts on things we could do better or things we could include, that would be helpful. And as I said earlier on, we are looking ahead to next year. So, what are we doing right? What are we doing wrong? How can we make how can we streamline the process and improve it? I think there's things that are working well that I'm really pleased with. There's other things that I think actually we could perhaps do that a bit differently. And as with all these things, it's a bit of an ongoing process rather than a perfect model or a perfect destination. But certainly feedback that although we will formally capture feedback as part of that process, if in the meantime you have thoughts or comments that you want to feed into me, then please just get in touch. I think you've all got my email address, but otherwise your local coordinator you can go through them. So I think that's me. I'm just going to quickly check if anyone has any comments or thank you. Sorry, I'll let Farouk just unmute everybody. If anybody had any comments or questions that they wanted to raise. Otherwise, I think we've got Kathy, who's our next speaker, on the phone already, so we can pass on to her in a minute. But just quickly, any comments, thoughts, or anything you wanted to mention or raise? Nope. Everybody's all quiet. Okay, thank you. So I'm going to hand over to Kathy, and she is involved in a similar but different project in Kent, which she will explain. But it's really just to get a bit of a flavour of what some of the things that are happening in other areas of the country and what's going on. So, Kathy, I think you've got control now of the slides, right. So I think you should be able to flip on to the next one. Is that right?
Yeah.
Lovely.
Hello, can you hear me?
I certainly can, and I'm assuming everybody else can.
Great. So thank you again for inviting me. This is the second run through. We did.
And thank you so much for making time again.
It's okay. It's an absolute pleasure. So I was just because I was worried about the technology, I wasn't earwigging on the end of that.
No, you're really welcome.
But actually, it sounds as though you're doing something very similar to what we did in the Vanguard. So for the last couple of years, I've been working with one of the Vanguard sites, one of the NHS Vanguard sites, to test out new models of care. And our Vanguard was called Encompass Multi-Specialty Community Provider. Well, that's me. I'll move quickly on. So this was really just trying a different way of working. Everyone knows the pressure we're under with the GP practices not able to always recruit to their full workforce complement, the growing pressures on the system, the older population living longer with more comorbidity. So we just came together, 14 GP practices across Canterbury. So there's some very nice pictures there of sort of Canterbury, Whitstable, Sandwich, Ash and Faversham. So in Kent we've got some seaside areas, some rural areas, and some sort of Canterbury city centre. It's a city because it's got a cathedral. But actually we came together to test a new way of working, and that was multidisciplinary team working. That's just an indication of where our geography is. So if you go any further sort of to the right, you'll hit France. So we've got our own issues with workforce because of our geography and the ease of getting into London. Some people would rather travel into London because we've got some high-speed networks. So sometimes it's very difficult to keep our workforce functioning, especially at primary care level. But they're the sort of the hubs that we came together in. So you'll see we were looking at the sort of 30 to 50,000, but you can see Ash and Sandwich there are a little hub of 17,000. Now we let them go on their own merry way, because actually the geography and where they're situated is fairly rural and very difficult for patients to travel to any of the other hubs. So we let them be a little sort of hub on their own. So we were asked at the very beginning of the sort of Vanguard 3-year sort of project, if you like, to actually put our model on a page. So this is it, and I think up and down the country you're starting to see the same models developing. So it's GP practices working at scale on the left there, that's the sort of blue circle in the centre there, and at scale means that GPs are coming together to try and consolidate things like workforce, to work with extended access, extended hours, all those other things that are going to maintain their sustainability in the long term, but trying to bring the other systems of care round the practices. And when we talk about systems of care, we're actually talking about the statutory organisations that maybe practices are used to working with, so that's the local community trusts and the acute trusts and mental health trusts, but social care as well from the local authority. But more importantly, I think the game changer for us in this model was coming together with the voluntary and care sector. How do we harness that community asset there to support GP practice? So that's what that integrated systems of care are on the left-hand side. And then deliberately the boxes are getting smaller as you go to the right, because actually our raison d'etre, if you like, is to keep the greatest number of people as close to the GP practice as possible with routine prevention, proactive care. So, and I'll talk about our anticipatory care planning. I heard a little bit on the end of your last presentation about the integrated case management and care planning, so I'll explain what we did. Then moving on, of course, people will always get into trouble. We can't anticipate everything, but actually, how do we try and keep people away from the front door of the acute trust? How do we have community resilience there that is reactive and can avoid admission? Or if people do hit the front doors of A&E, how do we get them out quickly so that they don't go into a hospital bed and deteriorate? Of course, moving on to the next box, we want our acute trust there, we want good, vibrant acute care, but actually we want that for when people really need it, and that's for the shortest possible intervention and repatriation back home as quickly as possible, especially with some of our cohorts of populations are frail and elderly. We want to get them back into their own home. And then the last box on the right is tertiary care, and we'll always need that for a very few of the population, but actually we need highly specialist intervention, but also the same goes for them, repatriation at the earliest possible opportunity. So as you go from left to right, your level of illness or your level of acuity is going up, but actually our, as I said, our raison d'etre was to work towards the left, and that was emergency admission avoidance and the greatest number of people being kept fit and healthy in the community. We started off by doing some population profiling to see what our population actually looked like, and then putting those into sort of risk bandings, if you like. So at the top there, we've got the very high risk and relatively high risk patients. Now, that cohort is our most vulnerable and frail, and I've put frail and elderly separately because you don't have to be frail, you don't have to be elderly to be frail, and you don't have to be frail if you're elderly. So that is our most vulnerable sort of risk assessment of our population. So it's almost 6% of the population. And interestingly enough, that takes a huge amount of if you look at the figure in red of 19.6 million, you can see that 6% of our population, the expenditure on emergency admissions, which isn't always the place we want people in that bracket to be heading for, is a huge sum. So that's where we started. So eventually we will look at the whole triangle, but actually when you're starting to look at where the best place to begin, I think targeting the area that you think you can change the model and make a difference. And actually, if you get the quality of care right, maybe we can save some money as well. I hate talking about the money up front, but actually I do believe if we get the quality right, we do make some savings in finance that we can then reinvest. So integrated case management, and I heard you talking a little bit about that. So that's actually about getting the teams together, getting, first of all, the agreement of the person in the centre of any integrated case management, and that's the person or the individual or the patient, whatever you want to refer to them as, getting their consent. And at the time that we started off in the Vanguard, we didn't have the new GDPR governance around sharing of information, so we had an awful job trying to put data sharing agreements between all the organisations so that we could share people's data with them. Now, interestingly enough, when we asked people if they wanted to consent to having a multidisciplinary approach to their care, out of the thousands of people that went through, we didn't have one person that said no, and the common denominator there was the comment that, aren't you already doing that? Because the general public assume that we're all talking to each other. So I think it's an imaginary worry. I know that there are regulations and we've obviously got to be careful, but I think the anxiety around sharing information, it sits more with organisations than it does with the general public in the main. So we launched the 5 hub sites that I showed you earlier, and we identified patients through a combination of sort of risk stratification through the GP systems, but also clinical judgment and any sort of just gut feeling of anyone within that MDT, the multidisciplinary team, that was just generally worried about someone. So we started off having weekly hub sort of multidisciplinary team meetings, but actually patients identified as having an urgent care need, we didn't make them wait a week. If we thought there was something we could do between the team, we would phone one another up and try and find solutions, because you know, we don't want to put people at clinical risk. So integrated case management was mainly for that top cohort of the triangle and to avoid future emergency admissions to hospital. And we looked at people with complex comorbidities, people that were deteriorating and we could do something with, those at future risk of hospital admission. So we really were looking at anticipating the things that might happen in the next 6 months. And those people that were generally starting to use the services more, they were visiting the GP more, they were deteriorating, and patients with underlying social and well-being needs that weren't being addressed, because our GPs would tell us that there were quite a number of people contacting them that, you know, a pill didn't fix their solution. Now you'll see in the top right hand corner there, we've got the model we were using was Dorothy, and it's Dorothy's care, but we have sat Dorothy's husband next to her, because what we were finding during this process that there was a lot of undiscovered carer needs and anticipatory care planning for what would happen for Dorothy if someone else, you know, if her partner, spouse or whatever got into trouble, or if they were the main carer for their partner or spouse, which is often the reality for some of our frail and elderly cohorts. That's a little pathway. So it starts off with triangle identifying the patient, then getting patient's consent, and that is actually a real, that's one of our real patients there. That's Valerie, and I think I sent a video round about Valerie. If I didn't, I will forward it on, because it's a 5-minute video and it shows the difference that multidisciplinary team work made to Valerie. But actually, the first thing to do is get Valerie's consent, but then set the goals for Valerie. What is it that what matters to Valerie? Or Dorothy, or whoever's in I mentioned Dorothy earlier, that's the model we're using across Kent and Medway, but that's Valerie, a real patient. But then getting the team together to actually look at the gaps in the care, trying to be more efficient, having one person going in to deal with some of the issues rather than 5 or 6 people, because we do tend to confuse our population when they don't know who's coming in and who's doing what, and one point of contact. So that's making us a bit more effective and efficient as a team, but also it's much easier for the individual to just identify one person as their main worker, and then regular updates and looking at the outcomes as well, because it's very important that we're not just doing this and that we don't measure the improvements. So integrated case management as of February 18, and the Vanguard, all the Vanguard projects across the country, the funding finished in March this year. So that's where they're starting to use all the learning for that to then help other areas in the country. But that was our eligible population. By February, we'd put 2,648 people through an integrated care plan approach. So that was about 150 on the caseload in any 1 month. Now, I explained the last time I did this WebEx that that caseload is very fluid. So it's almost like a virtual ward, if you can describe it in that way. So people can step up onto the caseload. They have their care plan and everything in place that meets their needs. They're deemed to be stable, and then they step down off the caseload. At any time, because these patients are getting older and other things happen, at any time they can come back onto the caseload. So that caseload, although we want to keep it revolving with different people all the time, it will be fluid, and people will come on and off. And at the time I left the Vanguard, we were seeing about 150 people on the caseload at any one time. The future expectation, and I think that's where they're up to now, is seeing an average of 350 on the caseload, because you know, we have to get the numbers up to actually start making a difference to our acute trust colleagues, so that they see the difference at the front door of A&E. Because the numbers at that time, although we were, I'll show you some activity deflection data, but it wasn't enough to actually make the difference that we need to see in the whole system. So that 150 patients was an average length of stay on the caseload for about 28 days. So some people are dealt with very quickly. Their needs might be quite simple, but other people might be much more complicated if they've got complicated health, social care, you know, mental health needs, physical health needs. So they might stay on a bit longer, but that's just an average length of stay on the caseload. So there you can see some of the activity deflections. So we really were, and this is data that was heavily scrutinised by NHS England. As you can imagine, we had quarterly reviews, and they went through our data with a fine-tooth comb. So we can actually say that we made all those activity deflections. So 33.1% reduction in short stay admissions, 8.2% on emergency admissions, etc. But what our acute trust was saying to us is they didn't see the difference. So in East Kent, our acute trust covers a population of about 750,000, and the Vanguard was about 300,000 of that population. So although we were looking at our own cohort of patients, it just proved that although the model worked, you needed to be doing it on a bigger footprint for it to have any impact on the whole system. And that's just some funding planned forecast savings that we made by keeping people out of hospital. On the right there are some patient experience comments, and at the bottom right there is just something that we developed, because it wasn't just integrated case management that we did. We put in a number of different sort of new ways of working in the Vanguard, and one of them was we developed an app called the Waitlist app, which shows all the A&Es and minor injuries in the whole of East Kent. It geolocates you. It tells you how many people are waiting at any one time. It tells you how long it'll take you to get there in your car and by foot or by public transport. And we found that people were starting to use services in a different way because they had the information in front of them, so they wouldn't necessarily turn up at A&E when actually they needed a minor injury that was less crowded. So that was just as an aside. That's why these slides were done for NHS England, so they obviously we've handpicked a few of them. So that's a bit of an anomaly, but it just shows you some of the other things we were doing. So the one thing I would say is that this is a challenge, and now that I'm spreading this out, and my role is now the local care lead across the whole of Kent and Medway, I'm trying to use the learning from the Vanguard for the rest of Kent and Medway. So I'm probably at the same, I probably feel for you, because I'm probably at a similar position that you are at the moment, because some areas haven't started at all. And it is a challenge. It's a challenge at a time when primary care is probably at its most vulnerable. I mean, in parts of Kent, we're really struggling to recruit the workforce, especially some of our GPs. So it is a challenge. It's a challenge not only with workforce recruitment and retention, but it's a challenge because the workforce that are out there are feeling quite jaded, and they sometimes can see this as, oh dear, it's not something new you're putting in now, we've had enough, you know, we can't cope as it is. So so I do say to people, if it was easy, it would have been done. So, you know, there's something down at the bottom there, I've put hold your nerve, because just keep going with it. The model will work, but we have to take people on that journey. And I think when you're looking at things like workforce, although we've got huge challenges, we've got a real opportunity to look at different roles, especially to support GP practice. And I don't mean that in a patronising way, but there are things that GPs are doing that other healthcare professionals could do. There's a lot of work being done up and down the country with using clinical pharmacists. There's a huge amount that just putting care navigation and social prescribing in can do, and that's a workforce that's fairly readily built. You know, they don't have to do 3 years training to be that, but all these new types of roles will reinforce the model moving forward. For us, one of the issues was governance. I think data sharing, although it's still a challenge, has been made much easier with the new GDPR guidance and policies, but still in parts, just sharing information across different IT systems is a real challenge, and we have to find ways of working around that until we can all interoperate. The middle one there, if there was one big message I would give anyone, it's actually to spend the time on the organisational development and engagement, and that's about getting the teams together, building the relationships, building the trust, and having the time to do that. Now, I know that's a huge challenge because we're all being asked to do things yesterday, and we're all being asked to, you know, to show the impact yesterday. But actually, if you don't get the engagement and the buy-in at the very beginning, everything's going to fail. So if there's one thing I would say I've learnt from the Vanguard work, and we could have been better at that, was to put in the organisational development engagement bit and really concentrate on that. I know in London, some of the areas, really Tower Hamlets, spent an awful lot of time doing that piece of work, and I think it paid off. It's about meaningful communication, so actually telling people what you're doing and people understanding why, because people won't engage if they don't understand why we're trying to do things. And for us it was, which probably it might not be an issue for you or May, but with some of the central funding we had for the Vanguard work was very slow in coming, which was very difficult for us to actually put new teams in place to test this. And that might be something of a blessing to you when I explain that because of the funding, we were only getting the funding quarterly, that to actually try and put new staff in place, you can't put someone in place that will accept just an ongoing contract just every quarter. So and we had real problems just getting staff, getting new teams. So we had to work with the existing teams that were there and try and refocus them, reface them. And I think some of the success was probably because I'd worked in East Kent previously and I knew a number of the community staff, so I was able to sort of use a bit of influence to say, oh, please try and help us make this work, and luckily they did. So, you know, I think there is something there even about the relationships and explaining to people what we're trying to do. So that's a very quick run through that.